myself first of all. My name's Ed Alveyn. I'm a member of the British Society of Rheumatology, if I can get my words out, operations team for the National Early Inflammatory Arthritis Audit, or NEIAA. And I'm also a research fellow at King's College London. And I work with Dr James Galloway, who is the analytics lead for the national audit, and heavily involved in the running of the project. Let me just share my slides with you. I'm also joined today by Sarah Gallagher, who's the project manager for NEIAA, and Callum Colwood, also from the BSR, who is the administrator for the audit, and they're going to kindly help with running today's webinar, including collating some questions from the chat. So if you have any questions about what I'm discussing, please do feel free to put those in the chat, and there'll be time to discuss them later on. Likewise, if there are any technical issues, please do let us know about that. And so that's who we are, but we'd also be very grateful if you're able to just pop a couple of lines in the chat saying who you are and what your role is, whether that's within a rheumatology department or audit department. That's really helpful for us because it confirms we're talking to human beings, and also it allows us to tailor our answers and the way we deliver the webinar. So if you could pop your details in the chat while I just share my screen. Be lovely. And I very much hope you can all see the start of my slides, but do shout if that's not the case. So as I say, I work on the national audit, and this is just a quick update on some of the changes that have been happening to the audit and are continuing to happen over the course of this year, and how that might affect departments locally. And it's also a reminder of how departments can get extra funding through submitting data to the audit and showing that we're delivering high quality care in rheumatology. So here we go. First of all, just a quick recap about the background to national audit in rheumatology. We first began a national arthritis audit for inflammatory arthritis in 2014, focused on trying to assess how well we were meeting the NICE guidance for rheumatoid arthritis and early inflammatory arthritis, which is NICE quality standard 33. And that primarily focuses on the prompt referral, assessment and treatment target of early inflammatory arthritis, as I say. So that was the primary objective of the start of that national audit. And just as a reminder, when we say early inflammatory arthritis, we're collecting data on rheumatoid arthritis, psoriatic arthritis, axial spondyloarthropathy or ankylosing spondylitis, and also undifferentiated inflammatory arthritis. In 2018, the audit changed slightly and became under the auspices of the Healthcare Quality Improvement Partnership. So a mandated national audit with extra funding and clout, with data also given to the CQC to help with their assessment of care quality standards. And we collected patient data on the actual cohort of patients we're seeing, as well as organisational data about rheumatology departments in the UK, and also patient-reported outcome measures. So data directly on patients on their own functional status, mental health, and other important quality metrics. So the first 5 years of NEIAA have been initially very encouraging in terms of improvements in the quality of care that we've seen as it's run in its current form since 2018. And that's for improvements initially in referral, assessment and treatment times in those key parameters of care in early inflammatory arthritis that we look for. Unfortunately, as with so many things, the pandemic somewhat stalled our progress and made those prompt assessment and treatment even more difficult, as many of you will be all too aware. And we await the 2023 data to see exactly how well we've managed to stabilise and bounce back from the pandemic, which, as we all know, has been very challenging to maintain the quality of outpatient care. So NEIAA, the National Early Inflammatory Arthritis Audit, it may yet be renamed later this year for reasons that I will come and touch on later in the talk. And there's likely to be a form of public consultation or even a public vote, perhaps on Twitter, as to the exact phrasing of the new name. So please do look out for that and contribute towards it. I'm very grateful for input from across the country on these changes. So it remains a QI project. Yes, it continues to audit against the strict national standards that we have in the form of NICE Quality Standard 33, but it also collects a wide range of other key performance metrics, include, for example, the patient-reported outcomes data that I mentioned earlier, which gives information on things like work participation and how early disease affects patients individually. It also collects information on patient ethnicity, for example, and we can see how differential care and outcomes are spread across the country in terms of ethnicity. I think we're all aware that there can be a tendency for quality improvement to take a back seat or be slightly forgotten perhaps in comparison to new research developments that come out, particularly in rheumatology, which is quite an exciting research-driven specialty. But I hope to be able to reiterate to you and try and convince you that audit is absolutely essential to making sure that we're delivering the care that makes the impact that it should do, and that translates all our hard work into genuine improvements for patients. And I hope to kind of offer a reminder that NEIAA offers a very powerful and useful tool to help us do that. So of course, we all know that our goal ultimately in what we do is to provide the best quality care with the resources that we have available to us. But most of us will also be very aware that those resources are not evenly spread across the country, resulting in significant variation in outcomes depending on where patients are seen and treated. And that's partly due to staffing issues, which are, as we know, are a major problem at the moment with the availability of consultants, nurses and allied health professionals, as well as other financial resource and estates and facilities and that kind of thing. But audit allows us to capture information about that variation in care, both through the organisational audit and the information we collect about what rheumatology departments are able to offer and in terms of outcomes. And it can be helpful to use audit data to bid for extra resource where it's needed, or to marshal our existing resources more effectively, and therefore boost the quality of care we're able to provide. Audit also allows us to measure care quality in terms of safety and important outcomes that are most important to patients. And data capture of this kind is relatively scarce in the outpatient setting. Most of the national audits that HQIP runs, for example, the Sentinel Stroke Audit, other audits related to joint replacement and orthopaedic surgery, for example, are very much secondary care focused. And the NEIAA is one of the few audits that operates almost exclusively also in secondary care, but in the outpatient setting rather than inpatient. In rheumatology, we are ideally placed to carry out this kind of audit because we have clear and evidence-based guidance to work from, such as the EULAR ACR guidance on managing early inflammatory arthritis, so the European and American bodies, as you see here on the right of the slide, as well as British Society of Rheumatology guidance, and of course, the NICE guidance in the form of QS 33 that I mentioned earlier. Our challenge, of course, is how to work out how we can adhere to the guidance and offer timely appropriate care for patients as soon and as often as possible. Clearly, our attempts to do that come up against resource constraints and the challenges of delivering outpatient care during the recovery from the pandemic. But if we really believe in the importance of the care that we provide, it remains essential that we're accountable and that we monitor robustly exactly how effectively we're delivering that care, now more than ever in these challenging times. And that doesn't necessarily mean that it has to be a clinician taking lots of extra time in a very busy clinic to enter data into the audit. And with the right support from admin staff and trust audit departments, much of that work can be shared and again made as efficient as possible. And we're hoping to continue to spread this message around audit teams around the country so that they can work more closely with rheumatology departments to maximise returns to the audit and therefore gather as much information about local and national services as we possibly can. Finally, recording our performance through an audit allows us to compare it to other services regionally or locally, or similar sized departments elsewhere in the country. And that allows us to identify scope for improvement if we fall behind other units, or make the case for greater resource allocation or modification of our services. So how is NEIAA changing? Well, NEIAA has been undertaking this type of national audit process for several years, as I mentioned. first in 2014, and then something close to its current iteration from 2018. The current iteration has just been relaunched in 2023 based on lessons learned from the previous years, with some important changes that we hope will make the audit more powerful, more accessible and less time consuming. In particular, we've reduced the length and number of forms to be submitted and the number of patients required to be enrolled. There are some new diagnoses to be included in the audit via a short, focused data entry form. But overall, that will mean a greatly reduced data burden going forward within the audit. The new version of our audit website allows visualization of performance over time, with comparison between sites in the same trust and by diagnosis as well. So in practice, we are changing the inclusion criteria to include confirmed cases only of autoimmune inflammatory rheumatic diseases that are typically managed in secondary care. That means suspected cases of things like rheumatoid arthritis do not need to be entered into the audit until the diagnosis is confirmed. And that removes a significant portion of the data burden that previously existed in the previous years of the audit. And using previous year's data, we estimate that'll be around about a 60% reduction in the number of patients required to be enrolled in the audit. A percentage of that will be replaced by the addition of the new diagnoses to the audit. But given that those are rarer diagnoses, we anticipate that will be a much less heavy data burden in terms of entry of patients overall. And the actual forms that require to be submitted for those new diseases are less onerous than for rheumatoid arthritis as well. So we hope that will help and achieve a substantial reduction in workload overall. So for rheumatoid pattern disease only, we ask for a 3-month follow-up form when the patient is subsequently reviewed in clinic. And we've removed the requirement for documentation of a 12-month review within the audit. So again, removing another stage of the process where clinicians or other team members have to go back and enter forms onto the audit website. The 3-month follow-up form will include information about disease activity through the DAS28 disease activity score as previously. And we will also collect patient-reported outcome forms from patients at baseline, 3 and 12 months. For all those who consent to be contacted by email within the audit. These prompts have also reduced in volume, and they will now include information on disease impact through the MSK-HQ questionnaire, mental health status, and also work participation for patients at diagnosis and over the 12 months following diagnosis. And these are really crucial to complementing the clinician and staff entered data that we collect within the audit. And I would really encourage you to sell those to patients as both a way for them to be monitored in more detail and asking exactly how their disease affects them, so for personal monitoring, but also for contributing to our understanding of the disease process in early inflammatory arthritis more generally, and also as well as for contributing to funding for their department locally, because patient-reported outcome form returns are a component of the best practice tariff that I will come and talk about later, which allows departments to gain extra funding if they meet certain criteria in the patient care pathway. So here are the diseases which are now included within NEIAA, with the sort of classic early inflammatory arthritis diagnoses included on the left, as they always were within the audit. And then the 2 categories of rarer rheumatic diseases that have been added as of April this year. And that includes on the connective tissue disease side, lupus, SLE, Sjögren's syndrome, systemic sclerosis, myositis or idiopathic inflammatory myopathy, and undifferentiated connective tissue disease. And then on the vasculitis side, we'll collect information on giant cell arteritis. We'll collect information on large vessel vasculitis that isn't GCA. So for example, Takayasu's, ANCA-associated vasculitis, other small and medium vessel vasculitis, which is ANCA negative, and finally Behçet's disease. The collection of those new rare rheumatic diseases is in process now in a pilot phase, and I would encourage you to get to grips with that and enter any new cases of those conditions that you may see as soon as possible. Again, it's a short form and doesn't require follow-up for those patients at 3 months and 12 months. And then we're going to make that data collection mandatory, as it is for early inflammatory arthritis, on the 1st of September this year. So you've got a little bit of time to get to grips with entering that data and getting up to speed with putting those new patients in. That expansion of towards the rarer diseases was mandated by HQIP at the last retender of the national audit, and that was over concerns that service redesigns in rheumatology departments to allow better meeting of the early inflammatory arthritis targets within the audit, concerns that was detrimental to patients with these rarer rheumatic diseases who may actually have a higher level of clinical urgency. For example, a patient with severe active vasculitis really needs to be seen promptly, as many of you will know, in clinic. And there was a concern that maybe the focus had shifted too much to early inflammatory arthritis. So it's a balancing measure to try and make sure that those patients are still being offered timely care, as our guidance suggests that they should be. So we're sometimes asked about what quality standards we are assessing against exactly for these new diseases, and some of the extra information that doesn't directly map onto NICE quality standard 33. And the key response to that is really what I touched upon earlier, about this being about quality improvement more broadly, as opposed to simply just audit against the 5 quality statements within NICE QS 33. We need to make sure that there's equity of care provision across all the diseases that we treat in rheumatology, and gathering data about sort of extra outcomes, such as those types of things that are very meaningful to patients, like work participation and mental health, is also a really important part of monitoring the care that we give. We do acknowledge the ever-present and ever-increasing pressure on clinician and staff time when it comes to entering data, but sadly, given that we lack robust systems to code outpatient data at the moment and make more of what we do sort of routinely captured, NEIAA remains the most powerful and useful way to get a clear sense of how we're doing in outpatient rheumatology care, and to benchmark the quality of care that we provide. For these new diseases, as I say, we're collecting the minimum possible amount of data, and we aim to use that basic data to link to other NHS data sources, such as routinely collected primary care data or admissions data to secondary care, so that we can try and acquire data about meaningful clinical outcomes, such as, for example, end-stage renal failure in lupus or visual loss in giant cell arteritis. And we can link and get that information, that data elsewhere, rather than that having to be coded by busy clinicians in the course of their normal day-to-day work. So that's part of our ongoing efforts to reduce the burden of NEIAA on clinicians locally. So why contribute data? Well, I hope that I've reiterated and helped to convince you or reconvince you that NEIAA remains a really powerful, effective way to identify gaps in the care that we provide. And the infrastructure that's already been set up means that trusts and individual sites where rheumatology care is provided have to do less legwork in terms of designing systems of quality improvement and audit. Audit data can inform business cases and requests for extra resources, and of course helps to meet our obligations in terms of adherence to QI and HQIP mandated processes, and feeds into CQC regulation as well. But finally, there is cash available for completing audit data and for successfully meeting certain rheumatology care parameters or outcome measures. And that's in the form of the best practice tariff, which are top-up payments introduced in 2010, which many of you will be familiar with, as a financial incentive to reduce variation in care and improve quality of care across the board. Those are fees payable by ICBs to trusts when the trusts provide evidence as to the care that they're providing. And in the specific case of rheumatology care and NEIAA, trusts can claim the money from ICBs using data downloaded from the NEIAA website, and that can be used to directly fund time for further QI activity in rheumatology departments or pay for administrative support for the audit. So that data is downloadable on the BPT section of the website, and we hope to produce a handy guide to make it more clear how to do that. But it's fairly straightforward if you go on the BPT section of the main website. Currently, that fee payable to trust stands at £144 per patient who meets all 6 BPT criteria listed on the screen there. Sadly, there's no gradation of that, so you don't get sort of part of the fee if you only meet 3, 4, 5 of those parameters, but you do get the money for all 6. So it's a significant chunk of money, about half of what we might expect to be paid for a new patient seen in clinic. And so the audit is another way that is, well, the audit's the way that is established, who has been seen and who's met the criteria, and patient data has to be uploaded to the audit in a timely manner in order to meet those criteria. So that's all I wanted to mention initially, and what I think we would do now is to just answer some of your questions about what was in that section of the talk there, and anything that's not been clear about the changes to NEIAA more generally. After that, for anyone who's interested, we do have a short video on exactly how to enter data within NEIAA, which is about a 12-minute video just on the actual logistics of going onto the website and entering data for someone who hasn't done it before. So let me just stop sharing my slides for a moment.
Thank you for a great presentation, Ed. We've had a few questions that have come through via email and a couple in the chat. Can you hear me okay?
I can, yeah.
Perfect. So the first question was around whether there's going to be a recording made available.
Yes,
I'll let you answer.
I can answer that one. Yeah, there's a recording. I think we haven't yet discussed, because we've done a version of this webinar previously by Dr Galloway, but certainly one or possibly both of those will be uploaded and will be available as a recording as well. Yeah, so don't worry if anyone's missed it.
Perfect. And then a question that we've had a few times is on the data set, why the patient's telephone number question has been removed.
Yes, that's been removed because I think there'd been some confusion about if the phone number was entered, whether the patient would automatically be sent PROMS forms to fill out by the audit centrally, as happens with the email. So if you enter an email address, those emails get sent out to patients automatically and can be returned very seamlessly. When a phone number is entered, that doesn't happen. So it's still possible to arrange locally by phone or by post for patients to be sent out paper versions of forms, but that responsibility is on the local site to arrange that, and then to ensure that the data is entered manually onto the audit website when those paper forms come back. So we've removed that telephone number to avoid confusion, but by all means, we recognise that not everyone is able to fill out electronic PROMS forms. So please, by all means, do continue to organise that alternative route, but wherever possible, use email, because it's just a more efficient way to get that data uploaded onto the platform.
Brilliant, thank you. And then following on from that, we have been asked, how often do they need to give PROM forms to patients in clinic? So how often will we be collecting PROMs?
Yes, under the new system, we collect PROMS data at baseline, so when the patient is diagnosed, at 3-month follow-up, and then at 12 months. And those forms are downloadable from the website. So those are the time points when we need to be asking patients to fill out those forms and then getting that data back onto the system, if it's a paper-based form that they're filling out, to get it back in a timely manner, particularly for the first form, which will contribute to the BPT best practice tariff segment for the PROMS data, rather than leaving the form a few months to then be uploaded towards the end of the year when the deadline is looming, to be trying to get that sorted and ticking over throughout the year as patients are seen. But as I say, if at all possible, email is the slickest way to do that, because the results will automatically be uploaded onto the platform and then be visible at various stages. So on the 3-month follow-up tab, you can see what data the patient has or hasn't returned, any particular flags in terms of high or low scores, and it's very easy to visualize on that platform.
Lovely, thank you. And somebody has asked for more clarification over quality statement 2. I will share the link to the quality statements in the chat, but if you wanted to talk about what quality statement 2 measures.
Yes, so quality statement 2 is all about, well, depending on which version of NICE QS33 you used, that the old version was time to assessment, and now time to treatment. So those are the big things we look at within the audit, really. Time to assessment in the sense of how rheumatology departments are able to fit patients in and see them promptly when a diagnosis of EIA is suspected, and then time to DMARD treatment, because we know that there's very good evidence that early treatment with disease-modifying drugs helps to control inflammation and reduce the severity of disease. So that's the sort of key thing we focus on with QS2.
Lovely. Ed, there was just another question there. Do we continue to collect 12-month data? As from the update, I was told that this was optional. Go ahead and let you answer. Sorry, Ed.
No, that's fine. No, so we don't. There's no need for us. We still collect 12-month PROM data from the patient, but there's no need to put in data on the 12-month tab. So as I comment on in the video, if anyone wants to stay and watch that, the way the website is currently designed, you can just tick no, the patient's not eligible for follow-up at 12 months, but we are hoping to just change that 12-month tab on the website to make it clear that that information is no longer required. I think there's just been a bit of a hangover from last year when so patients enrolled previously, around this time last year, would have been expected at that stage to have a 12-month follow-up. But any patients entered onto the audit from now do not need a 12-month follow-up entered by a clinician. Obviously, we hope they'll still have their 12-month appointment and be reviewed in the same way, but that doesn't need to go on the audit.
Perfect. Thank you very much, Ed. And that's it. I'm just responding to one question in the chat. So happy for you to move on to the next section.
Great. Thanks very much. So I will just share this 12-minute or so video. Again, just give us a shout in the chat if there's any problems with sound or other issues. It just runs through how to enter data onto the audit.
Ed, should there be sound in this section?
There should, yes. Sorry if that's not coming through. That was working perfectly when I was trialing with Callum before. Let me just...
I think when you click share, you have to tick something.
Have to retoggle. Yeah, I
Yeah.
toggled that before, but it's reset itself. Sorry about that, everyone. Let me just... Okay, let's try again. Just there should be sound fairly soon after we start, so just let me know if not.
Thanks for watching this video guide to entering data on the National Early Inflammatory Arthritis Audit website. So begin on the NEIAA homepage at arthritisaudit.org.uk. And once you're there, scroll down to the login button at the bottom of the page. If you don't yet have access to the audit platform, please contact your local audit lead who will be able to provide you with details. After clicking on the login button, accept the terms of agreement and enter your login details. Once logged in on the home page, pop it over Clinical Audit and drop down to Clinical Data. The system will display the most recent records entered for the site at which you are registered. If you operate at more than one site, you should have the option to select the relevant site for data entry from the drop-down box. Select the correct site and then click Add Record. You'll be presented with a data entry form for the patient, beginning with the first tab requiring demographic information. Please enter all the relevant information. Guidance is available for each item by hovering over the blue question mark next to each data entry point. Most of this demographic information will be available from the patient record. However, some may be more difficult to find, for example, smoking status or duration of symptoms. If data are being entered by someone who did not review the patient personally, we recommend developing local procedures to ensure that all of the relevant information is available for the person entering data. I will now briefly demonstrate the demographic data entry to allow us to progress to the next tab. As a minimum, the NHS number and date of birth should be entered prior to saving the patient record so that it can be identified again later on. Depending on the data entered, other fields may pop up, such as the date first seen by the GP, if that route of referral is selected. Again, this is information that will need to be collected and documented in clinic, as it will not easily be available later on. Once you've entered the available data, press Save on the right-hand side of the screen. As you can see, if important information is left unentered, the page can be saved, but will be marked incomplete with an orange warning message at the bottom of the screen and on the tab at the top of the page. If we then enter the remaining data, once all the data have been entered, click Save again and this should mark the page as completed, with a green banner where there was previously orange. If not all of the data are available at the time of form completion, the form can be saved as incomplete, but remember this information must be added at a later date for the record to be complete. Moving to the next tab for diagnostic information. We can see there's a smaller amount of disease-specific data to be entered. The diagnosis should correspond to one of the categories listed in the drop-down box. This can be edited at any time until the final record is locked. So, for example, if a patient is identified as having an inflammatory arthritis, but does not yet meet criteria for a diagnosis of rheumatoid arthritis, they can be entered as an undifferentiated inflammatory arthritis, and the diagnosis changed later if the clinical picture changes. If the diagnosis entered for question 2.2 does not fall under the category of inflammatory arthritis, the response buttons for question 2.3 will be greyed out, as these patients do not require further follow-up within the audit. The patients requiring follow-up are those diagnosed with an inflammatory arthritis who have peripheral synovitis in a rheumatoid pattern, which is suitable for treatment with a disease-modifying anti-rheumatic drug. These patients may have a diagnosis of rheumatoid, psoriatic arthritis, or axial spondyloarthropathy. This tab also includes a space for documentation of the patient's email address, so they can be sent links to patient-reported outcome measures. This will happen automatically at baseline, 3 and 12 months for every patient whose email address is correctly entered. The patient must have consented to have their email address used for this purpose. Please encourage your patients to take up this option, as it provides a route to obtain invaluable information for quality improvement, as well as individual patient monitoring. If patients are unable to use email, the PROMS forms can be printed from the audit website and posted to patients for return, but this will not happen automatically and will require local departments to arrange this and enter the data manually when available. Once again, when the data have been entered, click Save before moving to the next tab. The Clinical Baseline tab records important disease activity and treatment information. If these data are being entered in clinic, some of the blood results may not yet be available, so these may be left and completed later. As mentioned before, if the data are being entered by non-clinical staff, the information required should be clearly documented in such a way as to allow its easy location and entry onto the audit platform. If yes is selected as the answer to the question about drug therapy, further questions about the start date of the medication and the type of medication will pop up. The last section on follow-up emails will be completed automatically when these are sent by the system. Once finished, click the Save button as before. And that completes the information to be entered after the patient's initial diagnosis. If the data entered into the Diagnosis tab indicated that the patient does not require follow-up within the audit, then the remaining tabs will be highlighted green, as no information is required at 3 months and 12 months. In this case, the patient was marked as being eligible for follow-up in question 2.3, so the 3-month follow-up tab will require completion after that 3-month review has been completed. This tab provides a summary of the completeness of the patient-reported outcome measure forms sent to the patient at baseline and 3 months. As the questionnaires are completed, the summary results will be displayed on this page. If following the 3-month visit, the patient is still deemed to have a diagnosis of inflammatory arthritis with peripheral joint involvement in a rheumatoid pattern suitable for DMARD therapy, click Yes to question 4.1 and enter the disease activity and treatment information in the same way as for the baseline visit. As we've previously documented that the patient has already been started on a DMARD medication, the buttons for this are greyed out. Again, click Save when the data have been entered as fully as possible. And the 3-month follow-up tab is complete. The 12-month follow-up tab is still present on the website, but we no longer collect this 12-month data from patients who have been entered after April of 2023. So on this tab, no can be selected for the question as to whether the patient is eligible for follow-up. And the record saved at that point. You'll then see that all of the tabs are showing a green banner at the top, indicating that the record is complete, and a new blue button has appeared with the option to lock the record and fully submit the data with no changes possible after that point. So if we're satisfied that the data is complete and no further changes are likely to be made, we can press that button. Or ask for confirmation. And then you'll see that the forms are greyed out in their entirety and are unable to be edited. And that is a complete record submitted into the NEIAA Audit platform. Thank you very much for watching this video on data entry into the National Audit platform. If you have any further questions about data entry, please discuss these with your local lead for the rheumatology audit or by emailing the audit team at the BSR. Thanks again.
Okay, thank you very much, everyone. So I can see a few other questions there in the chat. Sarah, are you happy for me to work through those in order, or do you have any others you want me to go for first?
I'm happy to do that if you're happy to continue with the Q&A session. Alternatively, we can answer everything via email, so it's entirely up to you. We have still got 34 people on the call, so maybe it's worthwhile going through those. Do you want me to filter you the questions through?
Go for it if you have them. If you have them in front of you, that would be fantastic. Yeah.
Okay, I've just clarified. I think there was a slight miscommunication about the patient-reported outcomes. They are at baseline. Oh, I've missed baseline. Baseline 3, 6, 9, and 12 months. So it's quite heavy on the data capture from patients there.
Okay. Sorry, no, I think I clearly got that wrong. In that case, I thought the buttons on the website were just hangover from previous years, and we were going to get rid of those. But apologies if that was incorrect information.
That's okay. The next question, we answered the question about collecting 12-month data, didn't we? Yeah, that is optional.
Yeah.
Are we meant to be including patients with a new diagnosis of GCA, CTD, etc.? This is not mentioned on the NEIAA website.
Yes, so we are. The new diagnoses of the vasculitis group I included in the presentation, and the CTD group do need to go into the audit, and at the moment that's in its pilot phase and will become mandatory from the 1st of September. You're right, we do need to update the information on the front page of the NEIAA website, which I think will probably come once we've decided on how we're going to sort of brand that and change the name from the National Early Inflammatory Arthritis Audit. And so, yes, at the moment we're publicising that through these webinars, through our presentations at the BSR conference and our newsletters as well. But we will certainly update the website as soon as we can.
Lovely. There is a question. Is there a way that the audit can be linked to trust systems so that patient demographics are automatically populated when NHS number and date of birth are entered?
Yeah, that would be fantastic if that was possible. And indeed, you know, it could even, with some of the newer electronic records, import disease activity scores and other patient information. Sadly, because of the heterogeneity of electronic record systems and the difficulty in making all of those systems talk to each other, unfortunately, we don't have the facility to import that data directly at the moment, and relies on manual entry still.
Lovely, thank you. Is there a central processing of PROMS forms, and can we have access to trust-specific data?
There is, depends what you mean by central processing. So that any PROM form that's filled in electronically by the patient will automatically be entered onto the audit and contribute to the data there. As for download of trust-specific PROMS data, I would need to double check that. I think it's available, but I'd need to speak to Dr. Galloway and the rest of the analytics team and get back to you on that one. So we'll have to follow that up with email.
Lovely, thank you. Somebody's asked for a Word document version of the data set to create specific reporting tools with their electronic patient record system. That's fine. We can provide that. If that person just wants to email through to audit@rheumatology.org.uk, then we can organise getting that to you. A few people have asked for that, I believe, already, and we've provided it so that you can set up your own internal processes. Somebody has asked on 2.2, do you need a box for other on the printed forms? But I'm not sure, without looking at the data set, what 2.2 is.
That is about diagnosis. So the drop-down list for diagnoses. I think so. Other remains on the drop-down list on the website. I think, again, because of just lingering over from last year for patients who are still kind of under follow-up, who may have had that box selected. Because we're now collecting confirmed cases only, and the specific range of diseases that I outlined in the presentation, I think that's going to come off the website and therefore doesn't need to be on the new paper sheets, because if the other diagnoses don't need to be entered into the audit, essentially. So I think that will stay off. But yeah, Sarah, unless you remember anything differently from those discussions that we've had about that.
No, that's correct. That will slowly be removed from the platform, or actually probably quite soon. And then the final question that we've had is, why are using RA? This is on question 3. Why are you using RA outcome measures on form 3 when you wish it to be completed for all patients eligible for a follow-up, including AXPAR, PSA?
So that's because while some patients with axial spondyloarthropathy and PSA will fall into that category, they'll be relatively small in number. So that's follow-up primarily for, as I said, people with peripheral broadly symmetrical synovitis with perhaps an RA type phenotype, most of whom will have a classification of RA, but some of whom may have relevant skin disease and axial features that mean they do actually have a different diagnosis, but their peripheral synovitis has a rheumatoid pattern. Appreciate, lots of the time, for PSA, etc., we would use different disease activity measures. I think to try and keep it simple and capture everyone's response to treatment, with the acknowledgement that there'll be relatively few patients with other diagnoses that aren't rheumatoid who fit into that box.
Perfect, that's great. Thank you, Ed. Oh, is Ed frozen?
Get back to you if there's a different reason for that.
Hi, Ed. Sorry, I don't know if you froze then or whether I did.
I think it was my connection that dropped out. I don't know how much of that you got, but yes, essentially we're focusing on follow-up for patients with rheumatoid pattern disease, peripheral synovitis, and obviously the overwhelming majority of those will be patients with rheumatoid. Some may have had atypical AS or PSA, and so we've kept the DAS28 for all of them, but appreciate that's not exactly how we would look after those patients necessarily in clinical practice or monitor their disease activity.
Brilliant, thank you, Ed. That brings us to the close of all of the questions. Yeah, that's great. We'll be running another session in July, which will be headed up by Dr. Liz Price, who is a new clinical lead for NEIAA. You will find details of that
Thanks
to
very
register
much.
for that on the platform. Thank you.
Thanks, Sarah. Thanks everyone for joining, and happy to answer any other questions by email if people think of anything later on as well.